All right. So we're going to talk about pediatric stroke today. I have no financial relationships to disclose. I'm going to talk about use of some medications which are not licensed for this condition. So, be careful about using them. Um, we are going to talk about the epidemiology of strokes in children. So are they worth discussing? Are they so rare that we don't even need to talk about them much? How do they present? What are the historical findings, history and physical exam findings, and then outline an approach to a child with stroke? So what is stroke, first of all? Stroke, or what is also called as cerebrovascular accident, is defined as an abrupt loss of brain function caused by decreased cerebral blood flow. So basically, just like we have shock, where there is reduced peripheral perfusion, when it comes to brain, there is reduced perfusion to the brain, which leads to reduced availability of substrate. And the substrate we're talking about is mainly oxygen, but also, nutrients like glucose. We'll sort of talk about it in more detail, but it is very important to remember that there are significant differences between the developmental and etiology of stroke in children as compared to adults. Stroke is actually a top 10 cause of mortality in children in the US, so it is not so rare. And once you have a stroke, not only can it cause immediate mortality, but it might lead to significant morbidity in terms of loss of function, persistent neurologic deficits and costs. So just as an exemplar of what might present as stroke, consider this case. This was a case that I was sort of involved with, not directly, thankfully. 9-year-old boy who was playing soccer. He was running down the field and seemed to bump into another player and fell down to his right. He had a brief generalized tonic-clonic seizure and then became post-ictal. Brought to ED. Slowly he got more alert, but it was noticed that he was moving his right arm less than usual. So you can see, what are the differential diagnoses? It could have been traumatic brain injury with a impact seizure. As he fell, he had a seizure. So whether the seizure preceded the fall or did it happen outside, who knows? It happened when nobody was carefully watching him. Could it have been Todd's paralysis? He fell down and so he had a seizure. Maybe it was right upper limb involving seizure and so he has a weakness. Or could it be a stroke? And then his head CT was normal. So what is the significance of that? So if you look at the incidence, the highest incidence of stroke is in the neonatal period, and especially in premature infants, where the incidence can be as high as 100 over 100,000. It reduces to 25 to 40 over that, and in older children, it is much more. But as our example case implied, even a 10-year-old previously completely well, can potentially have a stroke. There's a mild male predominance. And this is a really important statement here. Its incidence is similar to that of brain tumors in children. And we always talk about brain tumors, right? We worry about how to diagnose them, how to treat them. We've seen cases, but we don't talk as much about pediatric stroke. So similar to adults, stroke in children also can be ischemic or hemorrhagic. And ischemic stroke can be arterial ischemic stroke, again, because of limitation of circulation by a developing clot or through an embolus, or it could be a venous sinus thrombosis, or it could be a hemorrhagic stroke where 50% would have vascular anomalies, and we'll talk about what kind of anomalies later on, or older children with sickle cell disease as well are prone to hemorrhagic stroke. So what are the possible underlying conditions? This slide gives you some of the examples. They can be arteriopathies, heart disease, and we're going to talk about many of it more. But as compare it to the adults, where we know what are the predisposing conditions for stroke: hypertension, smoking, diabetes, hyperlipidemia. Fortunately, none of those are present here, but in children, but they have other predisposing factors. Luckily, not as common as those in adults, but still they are there and they can predispose to stroke sometimes. So at the time of diagnosis of stroke, about 45% of children with stroke will have a known predisposing condition. But the remaining, so more than 50% will not have a known predisposing condition. They'll come, just previously well child. But once you do the workup, you might be able to find a significant condition in the majority of them. For arterial ischemic stroke, as you see, only 10% remain cryptogenic. So in the vast majority, you'll find some risk factors. In hemorrhagic stroke, again, 90% will have at least one risk factor. So further investigation is very important to try to find if not the etiology, the risk factors predisposing to the stroke. So the most important, if one thing we need to take away from this lecture is recognition and high index of suspicion. Delay in diagnosis is common in this condition, as one might realize. So what are the clinical manifestations of stroke? The hallmark of stroke is sudden onset focal deficit. And what can that deficit be? It could be a deficit, facial nerve palsy, some vision defect, weakness of upper extremity function, weakness of lower extremity function. They could be combined. There might be some voice defects, slurring of the speech. So any kind of sudden onset focal neurologic deficit, always think about the possibility of stroke. The other possible manifestations, altered mental status, sudden onset severe headache. Everybody has heard about, hemorrhagic stroke can present with a sudden severe headache. Seizure sometimes can be a manifestation of stroke. Posterior circulation stroke is a little bit different in that, it may not present with a focal neurologic deficit. It may present with altered mental status, dizziness, vomiting, ataxia, and some eye findings. So anytime a patient presents with headache along with dizziness as a significant complaint, remember, think about the possibility of posterior circulation stroke. Do a good examination, make sure you don't have any positive findings. So we all know, in terms of our adult stroke, it could involve anterior cerebral artery, middle cerebral artery, posterior cerebral artery, and then there is the vertebral system. So the similar thing in children, if there is anterior cerebral artery, there will be mainly weakness of the contralateral leg. With middle cerebral artery, mainly contralateral arm. You can have contralateral leg as well, contralateral face as well. Depending on the left or the right side, you might have aphasia, dysarthria, or sensory defects. With posterior cerebral artery, that is the occipital cortex, so you might have visual field involvement mainly. And with the vertebrobasilar system, like we mentioned earlier, headache, ataxia, altered mental status, eye changes. Just to go over the associated conditions, because if already, we've been talking about that pretest probability, right? So if you have any of these conditions, your pretest probability of stroke goes up a little bit. So if a patient presents with those manifestations, then you'll be a little bit more concerned. And what are these conditions for arterial ischemic stroke? Sickle cell disease. Remember, we'll talk about sickle cell disease for hemorrhagic stroke as well. So sickle cell disease predisposes both to ischemic stroke as well as to hemorrhagic stroke. And then other arteriopathies, Moya disease, I'm sure you've heard about it or read about it in textbooks. If you work at CHOP, you get to see those patients as well sometimes. Post-radiation therapy. So somebody who's had various kinds of brain tumors, they've had radiotherapy related to that, and that can predispose them to some arteriopathies. Children with Down syndrome can be prone to them. Various collagen vascular disorders, lupus, polyarthritis nodosa, those kinds of conditions. Prothrombotic conditions, we'll talk about them more a little bit. Cardiac disorders. So wherever there is a right to left shunt, and if it is not being corrected, then potentially a ambulance can go from the right side into the left side and up the internal carotid artery into the brain. trauma can cause dissection, metabolic disorders, infection, vasospasm, severe meningitis, whether bacterial meningitis, tuberculous meningitis, or any of those things can ultimately be associated with thromboembolic events. And then prothrombotic disorders, like I mentioned, various things like protein C deficiency, protein S deficiency. I'll not go into detail. We've all sort of heard about them. How about for hemorrhagic stroke? So the conditions associated with that are the most common are the vascular anomalies, AV malformation. The point is, unless you do imaging, and it has to be like MRI, MRA, you're not going to know about it unless it bleeds. So the first bleed, luckily, in many cases, the first bleed does not cause the full-fledged stroke. It may cause some, what we call sentinel event. So you might have some symptoms, you might have some headache, you might have limited weakness, which may be transient. But if the patient gets a full workup, you're able to identify the AVM and treat it before it actually ruptures, then you might be able to prevent the stroke. With AVM, often there might be a recurrence of the event as well if it is not identified. So especially in children with a hemorrhagic stroke or a full workup is essential so that you can find the underlying cause, because you can prevent recurrence, you can prevent further damage. Various kinds of coagulation disorders. Right, so just like, for other conditions at CHOP, this is one of our relatively newer pathways, but still it has been there for the last 5 to 10 years, approach to diagnosis and treatment of stroke. Most of what I'm saying is derived from the information related to this pathway, so feel free to refer to it. You don't need to take a picture, just Google on, CHOP pathway for stroke and you'll get it. So what are the screening questions? Just as we mentioned, related to the exam findings, you want to know if there is any neurologic deficit. You want to know if the altered mental status did the problem. And the key thing is that it's a sudden onset event, right? So you want to know, did the problem begin or get worse suddenly? Has it gradually been, problem has been worsening over days or weeks, then it's probably not a stroke. It might be a brain tumor, it might be some other neurologic condition, but it's probably not stroke. But if it happens suddenly, then you're extremely worried. We're familiar with some of these sort of adult screening tools. There's a face, arm, speech test, as the name implies. Face for facial drooping, A for arm weakness. You know how we tell them to keep it supine, and is there a pronator drift? Does the arm falls down? Speech difficulty. So similar tests can be used in children as well. And as you see, they have a sensitivity of about 75 to 80%. So reasonably good sensitivity. And we can certainly, if we encounter a patient, again, clinical decision rules have the advantage that if you're faced with a patient, you don't have to think as if it's a completely new problem and you're reinventing the wheel. Because if you do that mode of thinking, then there is more chance that we're going to miss some things. But if we already know some rule and apply that, then it becomes much easier. So, there's less cognitive load. So I would encourage everybody, if there is a load, even if it doesn't have a very high sensitivity, it is a useful practice to use those rules. So we've already covered that. So the other condition that we haven't talked about too much is the venous sinus thrombosis. So especially in younger infants and younger children, sometimes they can develop venous sinus thrombosis. And what happens with that, it may or may not be associated with, conditions like gastroenteritis or other, even mild URI, viral infections, which lead to dehydration, reduced activity. And so the assumption is that the blood becomes more viscous and you might have a venous sinus thrombosis there. And what are the descriptions? So if it's a febrile child, you give them paracetamol or ibuprofen, the fever goes down, you've hydrated the child with an IV, and still he remains lethargic. He's not wanting to be, wake up, give you a big smile. then think about the possibility that, maybe something is happening in the brain. So lethargy, persistent vomiting. So you have evidence of raised intracranial pressure. So basically symptoms and signs of that. So if he's old enough, he might complain of headache, otherwise lethargy, irritability, vomiting. We talked about hemorrhagic stroke, worst headache of my life. Suddenly the patient collapsed and then can't awaken, paralyzed on one side. So this is the history and physical. You want a detailed history with review of systems with past medical history to find out if there could be any underlying disorders. So there is a pediatric NIH stroke scale that has been developed, but it's not been, very well studied by other investigators yet. So we're not going to go into detail. So initial approach to a child, high index of suspicion, recognition that this could be a stroke in this child or at adolescence. You want to do your ABCDs, make sure those things are okay. D for disability, remember. How's his mental status? And then if you remain suspicious about the possibility of stroke, it is very important to institute immediate neuroprotective treatment. Because what you're trying to do is, there is a obstruction, let's say to the anterior cerebral artery, and the distribution, anterior cerebral artery supplies, this part of the brain, then the areas at the periphery, if you do good neuroprotective treatment, then you can protect those areas at the margins of the circulation, right? But if the infant becomes hypoglycemic, he has a high fever, you're not caring for him very well, then that area can extend and the deficit can increase. You want to do neuroimaging, and we'll talk about what. If you have a stroke response team, because this is just as a myocardial infarction is an emergency, you want quick treatment. Stroke is a medical emergency. It's a brain emergency. Your brain is dying. So you want an immediate response team. Let's take mechanical therapy, disposition. So like I said, in neuroprotective therapy, you want to protect the brain tissue, especially at the border. So that's the penumbra is the fancy name for that. You want to maximize cerebral perfusion, so bed rest. If suppose it's you're worried about ischemic stroke, then you want to keep the patient, flat. But if you're worried about hemorrhagic stroke or venous sinus thrombosis, where you're worried about raised ICP, then at 30-degree angle, so that hopefully the pressure will go down a little bit. You want to keep the blood pressure normal to higher limits of normal, so that there is good cerebral perfusion pressure. If there is any concern for hypovolemia, like if the patient has been having gastroenteritis, he's dehydrated, you want to correct that. Anemia, hypoxemia, you want the saturations to be more than 95%. If room air is not enough for that, then give him supplemental oxygen. Minimize metabolic demand. So if the patient has a fever, you want to bring it down. If the patient is having seizures, controlling the seizures is very important. And we know hyponatremia can sometimes cause altered mental status. Severe hyponatremia can cause seizures. Hypernatremia can also affect the brain. So it's very important to check sodium level, and if abnormal, then to try and correct it. What other things can we do to protect the brain? Keep him on the cardiorespiratory monitor, hourly, frequent vital signs. What fluids to use? So if the patient is well hydrated, well perfused, then you would just start normal saline at maintenance. If the patient is poorly perfused, then feel free to provide boluses till the patient gets into a state of normovolemia, and then continue normal saline bolus, normal saline infusion. So how about dextrose for maintenance? Should we use normal saline, or should we use, D5 normal saline? So this is sort of important. Studies have found that dextrose is not good for dying tissue. Somehow, if you go into the pathophysiology, etc., of dying tissue, whether it's in the brain or in the heart, if there is a lot of dextrose coming there, that can cause more apoptosis, more destruction, more problems. So as long as your blood sugar is on the normal level, you want to avoid dextrose-containing fluids in this situation. So just give normal saline infusion. But to make sure that the patient doesn't go into hypoglycemia, you can keep checking blood sugars, let's say hourly or something. And if it's dropping, then of course you will add it. And this is true for anybody more than 6 months. In young infants, they are more prone to get into hypoglycemia. Their glycogen reserves, etc., in the liver are not so good. So there, D5 is allowed. Supplemental oxygen, frequent checks, blood sugar, we talked about normothermia. So what are the initial lab investigations? The initial point of care blood sugar, whatever seems reasonable. CBC, you want to make sure the patient is not anemic. PT, PTT, in case there is a clotting disorder. Remember, hemorrhagic stroke can be predisposed to by these conditions. You want to check electrolytes, looking at the sodium, especially BUN, creatinine, glucose, calcium, ECG, just in case there is any cardiac disease. We mentioned right to left shunt predisposes to embolic stroke. In a girl who's crossed the menarche age, who's having periods, you want to always check pregnancy test. And then further investigations, we don't need to do right away, but something to think about as we work up the patient. And then if you are worried about it, always, alert the stroke team. If you don't have a stroke team, alert your neurologist so that they are aware and they can come and evaluate the patient. It might seem it's somewhat like appendicitis. If you think about all of us have seen appendicitis. I think 90 to 95% of patients of appendicitis are fairly clear cut. You can diagnose them during your sleep even. But there is that, small category of patients of appendicitis where you can be fooled. And I'm sure all of us have seen those cases as well, where no, it doesn't look like appendicitis and da. But then if you do the workup for whatever reason, they turn out to have appendicitis, right? Like Manish presented this child of 9 months old who turned out to have appendicitis. And the same thing can happen in stroke, and I saw a patient myself. This was a patient with sickle cell disease, so we knew he was at high risk. This was like a 16, 17-year-old patient who was referred from a community hospital for the possibility of stroke. All right, so there wasn't even very high pretest probability. And still when the patient came to our ED, so I work at CHOP, which is the tertiary center. The neurology team were involved. Their neurology fellow was there to greet the patient pretty much. And over the next couple hours with multiple examinations, the patient's examination was so sort of waxing and waning. In between, he was able to get up, walk around the room. He was talking. He wanted the telephone from his mother so he can, chat with his friends. And in between, he would become a little bit confused. And we were just wondering what's going on. Ultimately, the neurologist decided we'll just admit him to neurology floor. It doesn't need an emergent MRI. This was getting into 10, 11 p.m. And then, we were still, from the ED side, we were a little bit worried. No, that doesn't seem like the case. We should do an MRI. But, at that time, the MRI tech had to be called in from home. And he had already had a CT, I think, which was normal from the referring hospital. And as he was going to the floor, the nurse said they were putting him in the wheelchair, that the nurse told me that he just peed on himself. So this was a 16-year-old boy who was supposed to be awake, and he peed on himself. That made us again concerned. No. We don't like this. That means his mental status is not normal if he did that. And he had an immediate MRI, and that showed a full middle cerebral artery stroke. So remember, even though anatomically he should have had complete weakness of half of the body, sometimes it just doesn't happen. So if you have, all of these symptom signs, they have limited sensitivity. None of them have the 100% sensitivity. So if you have some symptoms and signs, you're concerned about a really dangerous condition, go ahead and do the next test as well. So the advantage of CT is that it is quick. You can get it right away. It only takes a minute of, exposure time. but remember that it'll exclude hemorrhage. If it's a hemorrhagic stroke, you will see it on the CT. But if it is an ischemic stroke, as those of you who practice with adults know, that actually if you have clinical features of a stroke and the CT is normal, that tells you that it is an ischemic stroke. Those of us who practice only with children sometimes forget this. And we might assume that if the CT is normal, that he's fine, which is not the case, right? In the first 3 to 4 hours after the stroke happens, in ischemic stroke, actually the CT may be normal because it takes that much of time for the tissues to develop the changes related to ischemia, etc. So don't be fooled by a normal CT in the first few hours after presentation. MRI, if you can get it, is naturally the preferred modality because it can show you the lesions in a much more sensitive manner. And even immediately after development of the ischemic stroke, you can see changes related to ischemic area. And then along with MRI, you can do MRA, which is magnetic resonance angiography. So you can see the arterial blood vessels as well, see if there is any obstruction. If you're worried about venous sinus thrombosis or any venous obstruction, you can do MRV. That will show you all the veins. So naturally it is advantageous. If you don't have that access to that, you can also do CT angio, which is next best after MRA, MRV. So of course, for every 10 patients that you worry about stroke, maybe only one will turn out to be stroke, just because the pretest probability is so low. So what are the mimics? What are the other conditions that they will be most of the time? Complicated migraine tops the list, especially when you have features that tingling of the arm, some weakness of the face. But by the time the patient comes to you, it's completely recovered. So then more often than not, it's going to be complicated migraine rather than some other underlying condition. Of course, it needs full evaluation, possible workup, but that's a pretty common condition. It could be seizure, post-ictal state, like we talked about, Tal's palsy, traumatic brain injury, infection, demyelinating conditions like Guillain-Barré syndrome. It's usually bilateral, but maybe the findings may be more prominent on one side. And then there's this condition called ADEM, demyelinating encephalomyelitis. And then, there's these somatoform disorders or functional or, so those are also an important category to remember. You remember it has to be a diagnosis of exclusion and, you have to have definite stress factors and all of those other things. But even if, there is history of stress, history of depression, don't think that that tells you that this is a functional disorder. You still have to exclude organic conditions because a patient can have depression and can also have stroke. But important to keep in mind. And then treatment should be guided by stroke team because as emergency medicine physicians or pediatricians, I'm sure you will agree that none of us has enough experience with managing this condition. So we would, if you're suspecting ischemic stroke, aspirin, systemic anticoagulation. So these are all possible treatments, which you will review with your neurologist, heparin, anticonvulsants if the patient is having a seizure. If it's a sickle cell patient, then you will consider exchange transfusion. And then thrombolysis, TPA, those of you again who practice with adults know TPA is advocated if you identify stroke within the first 4 to 6 hours. In children, there is no very limited studies. So there was this study where they did investigational study to see how feasible it would be to do it. They identified 93 patients across 17 sites, and ultimately only one patient was enrolled and was eligible for treatment. So it is, still a relatively rare condition, and to diagnose it within 4 hours of onset so that you can institute the treatment and then you randomize them into no treatment versus treatment, it's just extremely difficult. And then there are some contraindications to thrombolysis, similar to that in adults that you have to refer to. Naturally, the main complication of thrombolysis is bleeding because you're preventing thrombosis, whether it's in the brain in the GI tract or somewhere else, and some other complications. And then this is an emerging modality similar to adults, mechanical thrombectomy. So, if you have a really big clot obstructing a major blood vessel, like, I don't know, I'm not a neurologist, so I don't know much about it, but large vessel, maybe in the internal carotid, probably not in the internal carotid, in the interior cerebral or middle cerebral, and you can reach it with your fancy devices, balloon, etc. Then you can remove the thrombus. So our patient, as I implied, that 9-year-old soccer player, he was referred to. So at that time, he was first seen at a community hospital with that presentation. But since his mental status seemed to be, going improve, waxing and waning, he was referred to the tertiary hospital, where also initially, it was not felt that he had a stroke, but again, about 12 hours later, he had an MRI that confirmed the stroke. So you can see how sometimes, just based on how you start thinking about the condition, when he was referred, it was framed as a Todd's palsy / TBI, / just related to a seizure disorder. That's how he was perceived, and that's how it, the momentum carried on for some time till people realized that no, he had a persistent weakness in his right upper extremity and his mental status was not normal, and he had the MRI. I mean, I'm not sure if that would have altered outcome, but we talked about how, those neuroprotective strategies, at least it might have limited the weakness, etc. And you want to, do well by our patients and diagnose things if they are diagnosable at the earliest. So to summarize, remember, stroke is not, it is uncommon, but it's not extremely rare. Most of us will see patients of stroke in our careers, at least a few of them. There is often a delay in diagnosis, so a high index of suspicion is important. At presentation, the majority of the children would not have a known predisposing condition. So even in a previously well child, we need to be alert to the possibility of a stroke. A normal CT within the first 4 hours of onset of symptoms does not rule out an ischemic stroke. It rules out a hemorrhagic stroke, but not ischemic stroke. If you do it after 4 to 5 hours, then a normal CT would exclude it. If you want to be, definitive about it in the earlier period, you have to do an MR. Neuroprotective therapy, pathophysiology is different than in adults. Diabetes, hypertension, those are not the main factors in children. Stroke team centers lead to, potentially improved outcomes. So consider, thinking about it, set up a pathway about it so that if you have a patient, you can deal with it on an expeditious basis. I want to take this opportunity to thank one of my colleagues, Dr. James Callahan from CHOP, for sharing his slides.